We want to update you all on what is coming down the pike and what has just happened over the last few months in terms of regulatory issues and meetings that will affect transplant for quite some time. This is not a New York City subway map or a London map, but it looks to me like when I get on the subway, this is what I look at because I get lost. This is the roadmap that you all should be familiar with. This was a patient-generated map with help of other professionals in the stakeholders in this field of transplant. There's a paper, there's a reference there. I recommend that you all pull that up. It's a PubMed, it's free, and our tax dollars paid for it. And it talks about the journey that you're all going to be taking. Some of you have already been there several times, and some will enter into it at certain points in the lifespan, in the life course. But I'll briefly go through the main points here as we enter the journey, trying to find out from the providing physician, what do I do next? Who do I see at a transplant? How do I find a transplant center? Who do I talk to? Nephrologist, transplant physician, social worker, transplant surgeon, financial advisor, all the way through the system. And we're going to kind of dissect this and come back to it. So don't get scared. It's a subway map. So kidney transplants are the most frequent organ transplanted in the United States and internationally over all organ transplantations that are done around the world. And living transplant kidneys make up a considerable number of these, but so do, as we know, cadaveric. But it's the major one. It's also the major waiting list. We've got over 100,000 on the waiting list right now in the States. When I started my training, it was 70,000, and now it's over 100,000. And the numbers do grow exponentially. We're not coming in with enough kidney donors. There have been some policy updates, and fortunately, the National Organ Transplant Act came in 1984, bipartisan bill, which started to pay attention and give support for this concept of the difficulties in navigating the transplant field. It came up with the organization called UNOS, United Organ Sharing, which we're part of. Any transplant center has to be a member of UNOS, which helps acquire transplants and make sure that there's a fair distribution of cadaveric transplants and living around the country. And that's undergoing some changes. Also, the OPTN is the final rule. This was an Organ Procurement Transplant Network, another stakeholder-generated and federal agency which assures fairness in the transplant process. Again, starting around 2000, this has been updated every couple of years. And the goal here is to assist and facilitate the entire network of transplant stakeholders and make sure that, again, there's fairness in distribution. This transplant regulation also came up with another stakeholder called the Scientific Registry of Transplant Recipients. This SRTR group urged Congress to pass a bill and make some money available for a series of conferences starting in most recently 2022 to 2024 that we're going to talk about to ultimately facilitate this whole process and make it clearer and more efficient based on data that they have been looking and tracking, patient-related data and institutional-related data, provider data, to see what is the best outcome we can have for transplants. So there's an interaction of all of these agencies, which makes it very complex, very burdensome at all levels. But at the grassroots level, this organization, this advocacy group, and you have the ability to talk to your representatives to make them aware that you're aware that these policies need to be followed. Okay. So there was a growing consensus on continued opportunities for improvement in this difficult infrastructure. Academy of Science, Engineering, and Medicine had recommendations, highlighted the need to address inequitable access to the system, more information on the pre-transplant phase of this journey, which is no small order, post-transplant journey, outcomes of the recipient, outcomes of the donors. There really are a lot of different databases that need to be unified. So there was a bipartisan Senate committees on finance hearings, 2022, most recently in 2023, and the House Energy and Commerce hearing in September of 24. This was very recent to address these needs again. And another act, this is the act that was passed just in July of 23 from the OPTN, which looked at these four main themes: to build a capacity for modernization of this infrastructure, make the data available for critical decision-making, engage stakeholders, and improve the OPTN functionally. Again, you can see the bureaucracy building here, and everyone has their fingers in the pie, and it's important that they communicate in a common goal. So this act, this US OPTN Act, should enable changes, removes the funding gap to the Health Research Services Administration, which means that there may be more money made available, hopefully. It's competing multiple contracts for this OPTN services to make it a better, effective mechanism if there's competition for these contracts. Mandate separate boards, and the key focus areas were technology, data, transparency, governance, operations, and quality improvement. Quite a large list of major goals. Then another stakeholder called the American Kidney Health Initiative, formed in 2019. Again, these are all stakeholders from different viewpoints coming together to try and lobby in Washington for what they want done. They wanted to, their themes were somewhat similar: increasing kidney disease prevention and early detection, improving access to transplantation, improving the care and treatments that are innovating care and treatments, addressing health disparities in the access to care, improving kidney disease education and awareness, and enhancing care delivery models. The last one is very innovative, and how will you effectively have a model of care at all levels of the community, be it urban or rural. So different focus from these stakeholders, but again, they overlap with some of the other groups. But they had a very large presence in Washington, and they really reached out to all organizations to sign on. So then we have another result of all these groups working and talking to representatives in Washington. They got the Center for Medicare and Medicaid Services. Everyone knows this. It's CMMS, which is undergoing changes and leadership. This model, the models that they came up with to address organ transplant access, called the IOTA, is brand new. So another set of regulations that need to be looked at and followed, proposed in May and finalized in November of 24. It's a 6-year mandatory model, begins July 1st this month, in 108 transplant centers nationally. If you're not part of that group, there's something wrong. That your center needs to be part of this group to be up to date. The key aim of this act is to increase access to kidney transplant, to improve outcomes and reduce health expenditures, and has a series of goals looking at access to care, time on the transplant list, outcomes from the transplant for the donor and the recipient, and long-term quality of life and financial burden. This is a map just showing the distribution of some of the centers with the 103 areas that are included. The blues don't represent anything but a color in this, blue and tan. There are major areas of the country that are represented, and some are not. And this applies only to the Medicare group that we're talking about. Okay. And there's different players in it. You have the Medicare, you have some Medicaid, and you have other providers. What they were looking to do was to provide incentives for performance at these 103 sites. The metrics of success would be achievement as judged by the number of transplants relative to a rolling target that's on their list of active transplants. And they would get points if they were giving more transplants to eligible recipients who are listed. The efficiency, which is the organ offer acceptance rate. You know, not everybody accepts a kidney in the middle of the night, even though at their center they've gone through all the hoops and said, this is a good match, we are offering it to you. You still have the option not to, and for various reasons. And Then the quality is the composite graft survival of the patients who received a kidney. So points are given, incentive and performance points, to these 103 centers. And if they don't reach a certain level, they may not be in the group anymore. So it's a way of putting some metrics into effect. What are the impacts of this CMMS and IOTA model? Well, the positives are enhanced incentives for transplantation, focus on long-term outcomes of donor and recipient, mandates transparency in the waitlist criteria for the member programs so that some centers don't have an advantage over others, simplifies and reduces the huge administrative burden. The number of people at each center and these networks, whether working in place or remotely, is enormous, and aligns with the Advancing American Kidney Health Initiative. That was the prior group that I showed you in 2019, came up with some proposals. There were some negatives. Again, it requires a lot of bureaucracy, a lot of information that has to be channeled appropriately, but overall, the positives far outweigh the negatives. And this is a work in progress. This just started July 1st. So there's no data yet. I suspect all the stakeholders will have periodic meetings, either in person or in Zoom, to get outcomes. There were several major committees of these groups. Each one's represented here. I'm sure NORD is involved somewhere along the line. I don't know the specific subcommittee, but everyone is involved in this effort. And the question is it a feasible system in terms of sustainability and donations? You know, at the end of the day, we need to get more kidneys. That's why you've heard in the news this year about a new approach using a genetically modified porcine kidney, which unfortunately worked for a little bit and then didn't work. But that's an attempt to fill the huge need of the waiting list. So more transplant donation, that's a whole separate area of awareness and policy and reaching out to the community. Some parts of the communities don't want to give an organ to someone. Others will gladly give an organ. That's a whole separate area that has to be built up and supported, so we don't have a list of over 100,000, which grows daily. And we expect to have more patients on the transplant list. You know, the epidemic of kidney disease and end-stage renal disease is real. We see it in the adults, but we also see it in pediatrics. And over the last 5 years, I'll just digress for a moment, because of research and interaction with industry and academia, we have now 2 or 3 newer therapies to combat chronic kidney disease in adults that we didn't have 5 years ago. You've all seen the ads on TV of the happy guy not getting on a dialysis machine, looking out at the golf course because of one. I don't want to mention the drug, but it's a drug that does slow down kidney disease in patients who have proteinuria and decreased kidney function. That's one example. Another one is the different drugs to treat the far overweight obesity problem, which can generate diabetes and other conditions, heart disease. There are drugs being used for that in adults. And then we have even a third agent that's being used to help protect the kidney in proteinuria kidney disease in adults. So there's amazing data from around the world on preventing the end-stage renal disease epidemic. In children, it's being applied where the United States is a little slower than Europe in some of these trials, but there are trials now with the SGLT2 inhibitors to slow proteinuria kidney disease. We have 14-year-olds in the clinic with diabetes type 2 on one of the other drugs that we're talking about that adults get. So we'll see outcomes over time. How it relates to transplant in children and in adults, well, there may be a time when we have fewer patients needing transplant because of these interventions, and they're relatively new. So some of the challenges in the transplant nephrology and kidney transplant area are workforce issues, and workforce to some of us in the audience, especially the nephrologists, means a shortage of people going into the field for a lot of reasons. That has to be addressed. We are at a critical shortage of nephrologists, both pediatric and adult. And transplant physicians are very rare to come by. So support for that, whether it's financial payback of loans that they've incurred, et cetera, but there has to be some efforts to keep them in this field. Also, a share cared model for recipients. This will depend on engagement with general nephrology for both referral and aftercare expansion. You know, these patients don't always have to be followed at the center, especially if they live in a distance from the center, and they can be referred back to a referring physician as long as you have good communication. There's lots of ways to do the remote care to prevent cost or loss to follow-up, and that would be innovative changes. And changing the practice to limit kidneys recovered but not used. I had a slide there. I may have gone on too quickly. We discard kidneys. Somewhere to 30% and up of kidneys that can be used are not accepted for one reason or another. That's an amazing loss of the organ. So that's something that needs to be addressed. We don't want to have a discarded kidney at any center. You know, people are waiting all over the country for these grafts. And evaluate the utilization of an ex vivo perfusion on transplantable organs. This is science coming, this is translational science coming to the table from the lab to literally the table. How an organ is procured from a donor and how it's preserved for transport. It's not like they take it from one room to the next. It may go from across country overnight. Preservation of that organ so that there's minimal damage, so when it's placed in the patient, it immediately functions is a whole important area of research funding. And also address out-of-sequence allocation. You know, if someone's on the list, they don't want to be bumped. That sometimes happens. How does that happen? How do you prevent it? That needs to be looked at critically, too. And as a patient and caregiver, what should I be asking? Well, is the transplant center part of the new IOTA that you're going to? You might want to find out from your physician if it is. If so, what do you think it will do in terms of the evaluation and workup, the transplant and post-transplant care? These are the criteria and incentives that they're supposed to follow. And am I considered a high-risk patient? And if so, how do I participate in that system? Does the center have new plans for the evaluation process? Does the center have new plans for communication and to the referring nephrologist and aftercare? And if not, has the center made any changes in the transplant evaluation and criteria evaluation process and post-transplant care? In other words, are they up to date? Because these changes are coming fast, and they need to be. I want to end on just reading to you something that I think we need to pay attention to. And I believe in bipartisan government. Last summer, I did go to D.C. for a Hill Day with an organization called NephCure and spoke to people at all sides of the arena to look about a bill for kidney care. I know you have the Hill Day. These are important efforts to reach out with unified goals. But right now, the Medicaid expansion population in adults 19 to 64 will be greatly affected by the eligibility verification and work reporting requirements which may come to play with the new bill. If you're medically frail, which is defined by the regulation by the Secretary, and you are a caregiver for children up to age 14, you're exempt from this work requirement today. That doesn't look like that's going to be affected, thank goodness. It's possible that someone post-transplant may fall into the definition of medically frail for a period of time, but we don't know that yet. Right now, they're covered. The details of the exemption process will also be laid out in regulation, and we're not sure how far this is going to go and what the cuts will affect. But people are concerned about rural health care facilities being cut. Again, Medicaid is a major component to transplant care. This was passed started in the 60s when lobbyists and physicians and patients went to Congress, patient was dialyzed on the floor of Congress, and they passed the act for dialysis reimbursement through Medicaid. There's a website that you should all know about, Rare Faces of Medicaid, What's at Stake for the Rare Disease Community by NORD, North American Rare Disease Organization. And National Organization of Rare Disease, and that website is raredisease.org. They have an updated version of this information for you all to look at. So I wish you luck in the journey, and I think you can go from point A to the end successfully. Many have, and now we have a little more challenges that have to be met. Thank you.